technology can transform lives and transform futures. And I'm going to talk a bit about the networks that we've set up as well to enable that. What I'm going to do first is start with this very sad story, but a story that really exemplifies why technology is so important in transforming lives and actually helping people manage their disease in a way that not only keeps them healthy, but actually keeps them out of hospital and, in the rare exceptions, prevents them from dying. So some of you may have heard this story on the news a couple of weeks ago. This was on the BBC News in the UK. This girl is called Ella Kissy Deborah. She was a 9-year-old girl, and I say was because she sadly died in February 2013. And she was a severe asthmatic. She'd had an estimated 27 admissions to hospital with acute asthmatic episodes. And most recently, Professor Stephen Holgate from Southampton University managed to correlate spikes in air pollution with her severe asthma. And she lived near the South Circular in London, which is one of the busiest roads in the UK. And every time she was admitted to hospital with a severe asthmatic attack, there was a spike in air pollution on that road, and she used to walk to school every day. Now, why this is such a step change in the NHS and broader healthcare is because this is going to be one of the first times, if not the first time, that air pollution will be put on a death certificate as a cause of death. Now, why am I telling you that? Because actually there are now platforms out there that you can identify air pollution, and platforms that link into symptoms and help asthmatics decide what they should do, alongside those with other respiratory diseases, to help manage their disease at home. And the question then to ask is, if she had the technology then, could we have prevented this very tragic death? And actually, I'm not going to talk in a great deal about air pollution, but to say that some of the statistics released by quite eminent bodies, the Royal College of Physicians in the UK, the University of Sheffield from the Urban Studies Group, state that actually there's a lot of issues around air pollution. And what we're now seeing is a crossover between environmental factors and health. And what we're seeing is digital platforms that help enable us to understand what's going on in the environment and to manage our disease. And there's other great things going on as well. So I've brought a few friends with me that are at the back, and I'll talk a little bit about some of their technologies, but they'll tell you a lot more. So this is 3D printing, and 3D printing. So Mr. Ian Hennessy at the back, one of our paediatric surgeons from Alder Hey Children's Hospital, is going to show you a bit of the work he's been doing. But 3D printing is now revolutionizing the way surgery is planned. You can take scans and make 3D models to help plan operative procedures. This is actually in America. This is a place called the Mercy Hospital. This has been badged the hospital without beds. And this is really, I think, a very progressive move. And what these guys say is that this is not to replace healthcare in the way it's delivered now. It's an adjunct to healthcare. But this is like a nerve center. It's 4 stories high with loads of different screens. And the person that's operating that can communicate with doctors, they can pull up information from lots of different hospitals, and they can communicate in the homes with patients through both telecommunication and pick up data through sensor technology. And so patients can be managed very effectively at home, but also this center is designed to identify problems in patients and then bring them into hospital when needed. And they link up with 43 different centers. And virtual reality now has been used to plan is being used in the operating theatres as well. So here's a surgeon using virtual reality as an overlay on a screen to understand his operative approach. And this was actually developed in collaboration with fighter pilots on the principle that your reaction in surgery has to be remarkably quick. And just the same as a fighter pilot flying a plane, it can be life and death within seconds or even less. It can be the same for the patient on the table as well. So what surgeons are doing is employing virtual reality to help them plan and to make their moves before they go in and do what they need to do. Okay, so many years ago, we thought about child health technology because there was a lot of stuff going on in adult healthcare. And many years ago, I used to attend national meetings, and we'd say, well, we'd have devices on the agenda, and there was a bit of a tumbleweed that would blow across the floor when it was mentioned, because nobody really knew what was happening out there. And when there was something happen, there was two issues. First of all, it was confined to very small areas of the country, or there was duplication. You'd find one area of the country was doing it, and then another area was doing roughly the same. And so there was a lot of overlap in development, a lot of duplication. One of the other issues, and I'm going to talk about this a little further on with one of the groups that we've been working with, was this issue of repurposing technology. And the pharmaceutical industry did this many years ago, and decades ago, when they said, here's a drug, we'll make it for an adult. And because a child is half the weight, or a quarter of the weight, let's make it half the dose or a quarter of the dose. No thought about whether the absorption of a drug would be different in a neonate from a small child from a bigger child. It was a very pragmatic and simplistic approach. And what we're seeing in technology, if we don't move quickly, is the same thing happening, that technologies are taken from an adult size and they're made smaller with no real thought about whether it truly fits in with the physiology and anatomy of a child. And there's a real compelling need to drive forward child health technology. And often children do get left behind in these processes. And one of our jobs is to make sure that actually they are front and center stage in this growing area of med tech and health tech. But you can see there, preterm babies, huge costs. Adult mental health problems, about 75% of those problems actually have their origin in childhood and with young people. We've got 800,000 children and young people that are disabled in this country. We've got a significant population of asthmatics. And actually rare diseases, they're rare individually, but common collectively. 1 in 17 children and adults have a rare disease, of which a significant portion of those are dying by the time they get to 5 years of age. And actually, the health system for many years, and without getting too political about this, and I don't think this is just common to the UK, it's common to many countries, is that what we do is we deal with the here and now, which is there are big problems out there. Heart disease, stroke, dementia, cancer, non-alcoholic liver disease, loads of different things going on that we're dealing with in adulthood, yet they all have their origins in childhood. And so what we do is we react to problems as opposed to be responsive to problems by starting early. And I use this phrase, a change in time saves 9, which is an old phrase that we use here, a stitch in time saves 9. If you get it right first time and early, we'll see a much healthier adult population. And if you think that the average life expectancy in the UK is 78 for men and 82 for women, the predicted life expectancy for a baby that's born today is well into their 90s. So we're going to have some big problems on our hands with a big burgeoning population. And if they're not made healthy now, we're going to have real problems well after I pass away, but there will be for the future. So we need to react much, much earlier on. And the question that I always answer is, in terms of why children, is because actually they're a big population. In this country, if you take up to 21 years of age, actually just up to a quarter of our population are children and young people. And that's an incredible amount for one country, particularly when you think that in the UK, we have a bigger population of children than many total populations of European countries. And actually, there is an economic argument, quite simply. If you invest early, for every pound you spend on a child, that actually over the lifetime of that individual, your return on investment is £10. I think that's pretty good investment odds. So if you were to talk to someone in the financial sector, they'd say, I would invest in a child if that's what I get back. Okay, so if we don't intervene early, there are risks. And what we do know, and I know I am talking to a big audience of young people, but what we do know is that the skills that you develop through your childhood and adolescence will stand you in good stead for what happens in adulthood. And actually, for those with long-term conditions, there are adverse consequences of not providing the right care early. So, for example, an increased risk of mental health problems, more adverse and risky behaviours, and also a risk of unemployment. That we know it actually, if young people don't get the support they need with their condition, that their employment opportunities go down. So actually, from that, we have to say, well, if we work with children and young people and industry together with healthcare workers to drive forward the agenda to say, let's look at technology to create new models of healthcare, where actually what we try to prevent is people coming into hospital and seeing us there, is can we deliver healthcare in a different way in the community where we give children and young people better opportunities, better peer-to-peer interaction, and better societal opportunities, and better educational opportunities. That leads to better health and well-being, a reduction in mental health problems, and better employment opportunities in the future. So there's a real economic drive here, as well as the obvious need to invest early with technology that can deliver new modalities of healthcare. And Ellen's spoken about one of those previously, this idea of getting information in a different way that means that you don't have to see your doctor face-to-face. And the question I often put back to health professionals and to industry leads is to say, does a patient need to see their doctor? Not a question of want. Do they need to see their doctor? Because if a patient comes and sees me, they have to come from their home. Sometimes they may travel for an hour in traffic. They then have to park around the hospital, which, if the same as hospitals around the world, we have very limited parking in hospitals. That could take them 30 minutes to park. They then register, sit down, they wait, they see me, and they leave. That's half a day lost of education. And that's half a day lost work for a parent. And so that's what I say back is, do patients need to see doctors, or can we do this in a different way? So we got to thinking about how we address this, and we started with this conversation in September 2013, and then got to acting on it in 2014. And we started with this a proposed network called TICH, Technology Innovation Transforming Child Health. I may have inspired that name at the diminutive size of 5'6", but TICH is a network that is established to support children and young people with developing technology. So where we started was we started with workshops, and what we wanted to do was to identify unmet needs, true unmet needs. And actually, what was interesting about the workshops is we started them with clinicians, academics, and industry partners, and then worked with patients and their families. And we found two different areas, one where there was a real clinical focus, and one where patients, children, young people, their families, were really, it was more about a social focus, what they needed in their lives to make, to support what they were doing. And there is an overlap in between those. And then what we went on to do was, from those workshops, we started to find what those unmet needs were. And we've worked with funding bodies across the country to start funding industry partners and collaborators to start developing that technology. So one of the major calls we launched a couple of years ago through a group supported by NHS England called the Small Business Research Initiative was this called Self-Care and Independence for Children with Long-Term Conditions. And we split it into two areas of focus. One was around about rehabilitation. The other one was about remote monitoring, this principle of gathering important information from patients and their families and making use of that in a credible and useful way. And there's some of our exhibitors at the back that will show you some of the work around that. And then one of the other areas we've been working in, alongside a group called Devices for Dignity, which is supported by our National Institute of Health Research, is this group called this network called Starworks. And this is a prosthetic limb network that is set up to get the best prosthetic limbs for children and young people at a cost that is realistic for the NHS and other health systems. And Limb Power at the back, they will talk to you a little bit more about that. So when we started with the TICH network, we approached the children's hospitals in the country, of which there are 3 standalone children's hospitals, and there are some badged children's hospitals within centres. And so we asked them the same question. Are you struggling to deal with technology at a local level as we are in Sheffield, where I work? And the answer was yes. And actually how we formed was this network that we work collaboratively to support areas of health technology development in areas of unmet need. And there are multiple partners that are joined. This network has grown much more rapidly than I ever thought it would, but I think definitely defines the unmet needs and the real appetite to focus on the development of child health technology. And I couldn't put all the companies up on one slide that we worked with, because we've worked with, I think, well over 50 companies. But I'm going to talk to you a little bit about some of the different companies that we've worked with. So Steve Took is at the back there. Steve runs a company called Tookie Limited. And I'm going to draw your attention to the picture on the left-hand side there, which is, it's a young child with cancer. And when I started as a junior doctor, which was quite some time ago now, they had these things around their neck called wiggly bags. And the reason being was the central port was called a wiggly. It came out, and you needed somewhere to put it. And this was a cloth bag or a plastic bag that hung around the neck, and you stuck the wiggly in there. Infection control? Probably not. Safety aspect? You could probably hang yourself on one of those. Was it comfortable? Well, not if it was flapping around everywhere. Could that get caught and pull a central line out? Highly likely. And so what Steve and colleagues have done is they've developed the Tookie vest. And the Tookie vest is a vest that will hold a central line, and he's adapting this for other lines that come out of the body as well, in something that is considerate of infection control, is comfortable for the child to wear, and allows freedom of movement without any risk. And even for the most simplistic of approaches, the appetite for this technology is massive. And Steve is really in great demand now from a number of different centers, all looking for this type of, this vest. So I mentioned to you about repurposing technology, and I think this is a great story of how technology fails to be repurposed from adult technology. So these are children with, that require non-invasive ventilation. So many of these children have muscle disorders where their lungs are weak, and their respiratory tract will diminish overnight, and they'll become very sick. And there is a risk of them dying if they don't have this non-invasive ventilation. So they have a face mask, and one of my colleagues in Sheffield, Professor Heather Elphick, worked with patients and families to understand what the problems were with non-invasive ventilation. And they were basically twofold. The first was that if that mask doesn't fit properly, remember this is a mask that's just been made smaller, if it doesn't fit properly, the machine alarms. Now, if you're a parent with two other children apart from the child with needing non-invasive ventilation in the family, that alarm goes off every hour. You and your family are up. And then as a parent and the other kids have to get up and go to school and work in the following day. And many of these parents were saying, we are getting to the point where we're struggling. And so what we realized then was that there was a problem with that mask. The second problem came in that the parents were saying, to deal with this, we've got to tighten the mask really tight to get a good seal. And these children were ending up with quite disfiguring pressure sores. So to overcome the problem, the solution was terrible. So what Heather and her team are working on is 3D facial scanning, which is this on the right here. And then what they'll do is they'll have a generic base and then a printed mask that fits exactly to that child's face. And then what happens when that child's face changes in shape, of which it will do as the baby gets older, is they throw that bit away and they make another one. So it's a bespoke solution that will overcome the problems there. So I mentioned about Starworks. It's incredible to think it wasn't that long ago that artificial limbs looked like this. And I say not long ago, certainly within the last 20 years, but we're now moving to develop prosthetic limbs that look much more like this, that are comfortable, the socket fits nice, they are considerate in terms of weight for the child, and so we're moving into a whole new revolution of prosthetic limbs that will be enablers for children with limb defects. Just want to talk very briefly about the next stage of our journey, which is the NIHR Children and Young People's MedTech Cooperative. So there are 11 MedTech cooperatives in this country, and this is the newest and the only one for children and young people. And this came off the back of the TITCH network, in which we applied competitively to our National Institute of Health Research, and for those of you from the States, that's the NIH equivalent, and we were funded to support this MedTech cooperative that will drive and it will accelerate the development of child health technology and support the adoption. And it's led from Sheffield Children's Hospital, but we've got multiple partners, and the idea is for us to work as a consortium, as a cooperative, around the country to support the development of technology in key areas of high disease burden and high need, of which those are listed on the right there. And the important thing is that each of these centres has a key opinion leader in one of those areas on the right-hand side. So they will lead the way in that technology development. And at the bottom there, a very important one is transition, the movement of children and young people from paediatric to adult healthcare, of which there is a big need for technology to support that, both in terms of engaging with young people and also making sure that clinicians remain engaged in that process so that the journey is genuinely a transition and not a transfer. And so we're working with groups. It's not the most exciting model to look at here, but the principle is really important. So on one side, which was around the workshops, is about market pull. You guys as patients, clinicians, and working in other fields, you know where the needs are. You know what's needed for your health, for your condition. Academics sometimes do, clinicians do as well. But what's been interesting is this principle of technology push. So there is some amazing technology out there. I saw some yesterday. I visited Canon Medical, and it's just mind-blowing what's out there. But actually, clinicians are quite narrow-minded in the way or narrow-viewed in the way they look at things, because we're incredibly busy people. And trying to understand what technology is out there takes some time. So when our technology guys say to us, have you thought about this? The clinician's eyes light up and say, oh, great, I can use that stuff now in that particular field. And so what we do is we generate unmet needs through understanding the technology. And we move towards this idea of a prevention agenda, which crosses over these two areas, market pull and technology push, where the prevention agenda is keeping healthy children healthy for as long as possible into adulthood and preventing people from coming into hospital, but also this novel and advanced care agenda, how we deliver care in a different way in the community. And we've done lots of things. I won't go into these in great detail, but we've run workshops, we've supported grants. We're working with IBM on a transition program with actually young people, with graduates from various universities to understand how we can facilitate transition. We've worked on a funding call for child and adolescent mental health. And then Ian Hennessy at the back, he's about to, or will be launching relatively soon, the Super Surgeon Program, which I think is a lovely name, which is to think about surgeons and what they would like as superpowers. If you said to a surgeon, what would you really like to do as a surgeon? What would be your superpower? But actually, what you then start to understand is what they really want to do, what they need. And then we can start to think about whether that technology exists to align with that. And the industry face a number of different problems. And I'm not going to labor this point because it's more detailed than perhaps we need. But there are lots of challenges around about working, or industry working with health services. So there's things about cost effectiveness. There's things about intellectual property. Some are finding health systems very difficult to navigate around. The NHS is the NHS as a badge, and we talk about it like this single entity. It is multiple different parts of a system, all behaving independently, sometimes and collaboratively at others. So industry, as you can imagine, is struggling to see ways in, particularly the smaller companies. And actually, the other problem that we need to overcome, and we're working on this, is the type of research that we speak about traditionally, those research cycles of ethics approval, get a study going, perhaps a randomized control trial. You've spoken about that this morning, and I understand very eloquently, is that those research cycles sometimes take 3 years. And technology is advancing so quickly that companies can't take that time to get their technology to market because the technology is outdated and there'll be another 5 or 6 companies coming through all doing roughly the same thing. So we have to think about how our research cycles fit in with technology development and adapt that we can do clinical evaluation rapidly and at low cost to get technology into healthcare. So I've spoken a bit about technology networks. That's what's happening within England, and we're crossing over into Scotland and thinking about this on a UK basis, and how we work collaboratively with industry, working with industry, clinicians working with industry and academics to support technology. But one thing that is fundamental to what we do is that we put the patient at the heart of everything we do on that innovation pathway, right the way from unmet need through to that product development and launching that product. Because what we're trying to avoid is technology going into that valley of death, that millions of pounds are spent on technologies that come to market and either can't integrate well into a service, or young people say, yeah, the technology works, but I hate it. I would never use this in a million years. And the reason being is nobody remembered to ask a young person what actually that technology should be and what it should do. And so we're moving away from that to make sure that patients and their families are integrated into those discussions and developments as technology comes through. So finally, I want to leave you guys with a problem, because this is a problem that's been vexing me for some time. And I've heard you were great this morning, so I want you to email me with a solution to this. Because these are the sort of problems we have. And when we talk about technology, people think of whizzing, beeping things. This is a real problem. And yet, you would think it's simple. And I have been in a room through an innovation workshop, and nobody's yet come up with a solution to this that really is viable. So, in young children, we collect urine samples. There are tens of thousands, if not hundreds of thousands, of urine samples collected in the NHS and around the world. And particularly in the under ones, they are remarkably difficult to collect. And it's a remarkably undignified way of doing it. So for those of you, the parents that have had kids, if you've ever tried to collect a urine sample, there is a high chance that you have ended up a very wet person at the end of that. Because what people do is they sit with a pot, and they sit with a baby, and they wait for that baby to go, and then they say, oh, I'll just reach over for my drink, and the next thing is baby's weed all over them. And the reason why we do this is we're trying to collect something called a midstream urine, which is a sample that is relatively clean, so that when we find bacteria in the urine, that we know it's definitely a urinary tract infection, and it's not just a contaminant from either the baby or the person that's collecting the urine. So what I would like to see is a device that can collect urine at a sample that misses the first bit of urine, collects the middle bit of urine, and misses the last bit. Sounds simple. So that's what I want you to take home today, and have a think about that and think, can I design something that can do that? For those of you who do, that you will be the savior of many, many parents that have had babies that have to collect urine, and actually you will also be very rich as well. But if you do it, can you include me in the whole process? So that just gives you a flavour of just one of the many problems that we're dealing with within child healthcare. So if you do have any ideas, any unmet needs, contact us. So this is our web address. There's a UK missing off the end there, but I'll repeat the web address in a minute. We've got a Twitter address, and then if you're interested in working with us, collaborating with us, if you have ideas or unmet needs, please contact us. And those are our two websites there. So that's the Titch website and the SIP Medtech website as well. So it's 12:30, nearly time for lunch, and I would like to thank you all very much for your time.